professionals, this is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. So let's resume our topic that was about narcotics. And point number one is about propoxyphene. And question is why it has poor bioavailability. It has two reasons. Number one is due to its poor release from the dosage form, and due to its chemical degradation from liver, gut wall, and metabolism. Because of these two reasons, it has poor bioavailability. By the way, propoxyphene is a drug which belongs to opioid analgesic category. Next point is about the antipsychotic drug. That example is the promethazine, and analgesic drug example is the mipyridine, also known as pethidine. These two combination is used for post-operative pain management because their synergistic effect increases analgesic activity. Next point is about the phenobarbital. Phenobarbital is specifically used for the seizure management, and as an anti-seizure drug, it is produced by the metabolism of primidone. Next point, that is point number 15, is about the pethidine, and the point here is that pethidine isn't used as an antitussive agent. There are some other antitussive agents we will discuss in upcoming points. Point number 16 is about the hyperkinesia. Is hyperkinesia yes, exactly, hyperkinesia is a wide variety of abnormal involuntary movement, and it is managed by the use of pimoline. It's an CNS stimulant drug, and is specifically used for hyperkinesia, and its advantage is only once daily dosing. Other drugs are also have the same efficacy, but its advantage is once daily dosing for the management of hyperkinesia. Next point, that is the point number 17, is about the naloxone. Naloxone is an opioid antagonist, and it is specifically used to counter the adverse effect of opioids, specifically, for example, respiratory depression. Next is the nalorphine. Nalorphine is a mixture of agonist and antagonist, and it has an advantage of codeine dependency codeine dependency withdrawal syndrome. Nalorphine is specifically used for this codeine dependency withdrawal syndrome, and naloxone is an opiate antagonist used for the respiratory depression. This was that point. Point number 18 is about the morphine. It causes constipation. It's one of its side effects. Point number 19 is about the methadone. Methadone is an opiate agonist drug. It oxidation causes formation of formic acid, which causes blindness. It is a very serious side effect. Point number 21 is about the post-operative analgesia. As I told you before, that pyridine or pethidine plus promethazine, this combination produces post-operative analgesia. Point number 22 is about the long-acting opiate examples. Number one example is the methadone and hydrocodone and nalbuphine. These are the example of long-acting opiate. Point number 24 is about the chronic bone metastasis. Chronic bone metastasis or cancer pain. It is managed by the use of fentanyl. It is an opioid analgesic class. It is specifically used for chronic bone metastasis. It is used for the management of this cancer pain. Point number 24 is about the nicotine. Nicotine is a least addictive potential. This drug is a drug which has a least addictive potential. So point number 25 is about the peptides. That example is the endorphins. It reduces stress and improves the sense of well-being. Second peptide example is the enkephalin, and it is specifically used for the pain management. So these are the peptide which is very important. Point number 26 is about the earlier sign of theophylline overdose. That is the tachycardia. When theophylline overdose, first of all, or you can say always, causes tachycardia. Point number 27 is about the dextropropoxyphene. Dextropropoxyphene, you can say dextropropoxyphene or D-propoxyphene is a half analgesic activity of codeine. It has a half analgesic activity of codeine, and on the other hand, levopropoxyphene is an antitussive agent. It's used with the dextromethorphan. Not with the dextromethorphan. It is classified under the dextromethorphan as an antitussive agent. Point number 28 is about the diphenogzolate. Yes, exactly. Point number 28 is about the diphenogzolate is related to meperidine. Diphenogzolate is specifically used as an antidiarrheal drug, and meperidine is also known as pethidine. It is an opiate analgesic, and it also has an anticholinergic potential. So, for the it causes constipation, and its adverse effect is specifically being used as an antidiarrheal activity. Their salt is available in pharmaceutical preparation is the diphenogzolate. Point number 29 is about the dextromethorphan, and it's a narcotic cough suppressant free from the addictive potential, and you can say produce less constipation compared to codeine. These are the point relevant to the dextromethorphan as less constipation, less constipation and less addictive potential, as well as it's a cough suppressant, and its dose is 15 to 30 mg TDS or QID 3 times per day or 4 times per day. Similarly, codeine 15 mg to 20 mg, as it was mentioned in book, 15 mg is usually sufficient to reduce the cough, and it's also acts as a cough suppressant, but the major is dextromethorphan. Point number 30 is about the treatment of constipation due to morphine. We use fiber-containing diets, stools, softeners. That example is the sodium docosate, and stimulant laxative like bisacodile. And if constipation persists, then we'll move for the osmotic laxative, that is the magnesium stearate and lactulose. These are the management step of constipation for due to the morphine. Point number 31 is about the codeine. You can say methyl morphine is also known as codeine, and acetyl morphine is also known as heroin. These are the chemical name, that is the diacetyl morphine, which is known as heroin, and methyl morphine, which is known as codeine. Codeine dose can be 30 to 60 mg, maximum dose can be 200 mg, but the point here was that their scientific name, that is the methyl morphine and acetyl morphine, diacetyl morphine. Point number 32 is about the codeine toxicity, and codeine toxicity is respiratory failure. Exactly, all opiate has this toxicity if given in a higher dose. Point number 33 is about the benzodiazepine, and those benzodiazepine which is specifically used for alcohol withdrawal. We have two options. That is, the first one is the alcohol dependency management, and second is the alcohol withdrawal management. As we use for alcohol dependency management, disul, disulfiram, and naltrexone, and a composite. We use these drugs for the management of alcohol dependency. Similarly, we use exactly. Similarly, we use benzodiazepine related drugs, that is used for alcohol dependency, and these drugs examples are chlordiazoxide. That's dose is 10 to 20 mg, 10 to 20 mg TDS 3 times per day. Diazepam 5 mg 2 times per day BD, and lorazepam 1 to 2 mg OD or BD. And these are very effective for the management of alcohol withdrawal symptoms. Point number 34 is about the caffeine. And it is caffeine. It's belong to the methylxanthine class, and it has a diuretic potential. Caffeine also has a diuretic potential, and it belongs to methylxanthine class. This was the point. Point number 35 is about the advantage of naloxone opioid antagonist, and naloxone is an opioid antagonist, and nalorphine is a mixture of agonist and antagonist. Advantage of naloxone is over the nalorphine is its lake agonistic potential. Nalorphine has the lake agonistic potential, and this was the advantage of naloxone. So whenever, if some, maybe it can be asked in comparative question of naloxone and nalorphine advantage over each other. So naloxone is an opioid antagonist, and nalorphine is a mixture of agonist and antagonist. So due to lake agonistic action of nalorphine, this is the advantage of naloxone. Point number 36 is about the Again, the pimoline, as we talk about pimoline for the many meta of hyperkinesia, as I told you before, hyperkinesia is exactly. So pimoline is an CNS stimulant drug. It isn't more effective than that of dextromethorphan or methylphenidate. Both are the CNS stimulant drugs, and it has a liver toxicity. The point here is that pimoline onset of action is 3 to 4 week, and its half-life, its dose is once daily. So its onset of action is very delayed. But other drugs like dextromethorphan and methylphenidate also have the similar potential. Point number 37 is about the dextromethorphan, which is the dextroamphetamine, which is the CNS stimulant drug, was preferred for the MBD, but methylphenidate is drug of choice. Dextromethorphan has an abusive potential. That's why it is not encouraged for the treatment of MBD. On the other hand, methylphenidate is considered as a drug of choice because of less abusive potential. Point number 37 is about just a reminder, as I told you before, that pyridine and pethidine are similar. Either if question is being asked by the use of mipyridine or pethidine, you will consider them both as a strong opioid agonist. They are the similar, just like as paracetamol and acetaminophen, they are similar. So in the same way, pethidine and mipyridine are similar because it's a strong opioid agonist. Point number 39 is that pethidine, as you know, that it's also mipyridine. Pethidine metabolite is toxic. Exactly, it is toxic because it's a opiate, strong opiate agonist. The morphine. Point number 40 is about the morphine is synthetic opioid. Methadone is morphine agonist, strong opionist. Point number 41 is about the diphenhexylate. It's an antidiarrheal drug. It's similar to pethidine and mipyridine. Point number 42 is about the pethidine, which is also known as mipyridine. It has point here is that pethidine potential for neurotoxicity, neurotoxic metabolite. It accumulate and causes seizure. So pethidine or mipyridine as neurotoxic metabolite, it accumulates and causes seizure. Point number 42 is about the metacocil. Metacocil, it's a xylem fiber supplement. In past, it was thought that constipation due to morphine is effectively managed by the use of fibers or xylem fibers, but latest research show that fiber supplement is unlikely to prevent or manage the opioid-induced constipation, but it can actually make it worse. So don't use fiber to manage the opioid-induced constipation, specifically morphine. So this was the point. Use other option like stimulant laxative and osmotic laxatives and other stool softeners like sodium glucosate, and use this option, but don't use this silent fiber for the management of constipation due to opioids. Point number 44 is about the cannabinoids. Cannabinoids, other name is tetrahydrocannabinol. Its isomer is dronabinol, and it's also known as cannabinoids or and then cannabinoids are tetrahydrocannabinoids are dronabinol. These are all same thing. They are different and known by different names. So point here is that these don't have any medical use. So we don't use cannabinoids or tetrahydrocannabinoids in any medical application. Point number 45 is about the morphine doesn't need loading dose. This is the point: morphine doesn't need loading dose. Point number 46 is about the group responsible for water solubility of nicotine. That is the nitrate. Nitrate is responsible for water solubility of nicotine. And point number 47 is about the active metabolite of morphine. Morphine has two metabolites. The active metabolite which holds 97% of analgesic activity is the morphine 6-glucuronide. Morphine 6-glucuronide is an active metabolite of morphine. 48 point number 48 is about side effect of opioids. Now I will tell you in detail. That is the sedation, dizziness, nausea, vomiting, constipation, physical dependence, tolerance, and respiratory depression. So these are the side effects related to opioids. So we use opioid antagonist if any side effect go beyond its limit. Point number 49 is about the diphenhexylate similar to pethidine, meperidine. Diphenhexylate is similar to methidine and meperidine. Exactly. Pethidine is the name of meperidine. So diphenhexylate is similar because it's a derivative form of opioid. Point number 50 is about alcohol plus CN depression. If you use alcohol and CN depression in combination, they will increase the depressive effects. Point number 51 is about the uh, exactly amphetamine and CNS stimulants. If you, amphetamine, which is a CNS stimulant, if you if we require to remove it blood from immediately due to its overdose or due to any reason, we will use ammonium chloride. Ammonium chloride. If we will administer ammonium chloride, which increase its urinary excretion of amphetamine, which is a CNS stimulant. Point number 52 is about disulfiram. Disulfiram, as I tell you about before, that it is used for chronic alcoholism, and it actually inhibits aldehyde dehydrogenase. This inhibition, what happens? It increases the sensitivity of ethanol. Once patient consume ethanol, the effect of hangover to be felt immediately following alcohol consumption, and this will happen that after consumption of alcohol, hangover effect immediately follow, and due to this effect, patient will get out of this chronic alcoholism or alcohol dependency. Secondly, side by side disulfiram is specifically used for chronic alcoholism or alcohol dependency, but metronidazole also interfere with the alcohol metabolism. So a person who is consuming alcohol side by side using metronidazole, here could be an interaction. Point number 53 is about opiate receptors, that is the mu receptor, delta receptor, kappa receptor. These are the three receptors where opiate drugs acts. Point number 54 is about the morphine CNS effect. The morphine effect on central nervous system, that is the analgesia, euphoria, sedation, respiratory depression, cough suppression, and meiosis, and uh, truncal rigidity, nausea, vomiting, hypo or hyperthermia, and sleep disturbances, and central sleep apnea. These are the effect caused by morphine on central nervous system. So I think so video is going too long, and next remaining part of this narcotic drugs will be shared in upcoming video. So thank you so much for your listening, and if you feel that your this effort is helpful for you, then please subscribe my channel and stay tuned. Before going to leave, I would like to leave here a question. If anyone knows its answer, then please comment below the video. That is the drugs that decrease the pain, drug that decrease pain, anxiety, load on heart. I will mention 5 drugs. You have to choose some drugs which decrease pain, anxiety, and load on heart. That is the example of drug is the number one: aspirin, morphine, furosemide, digoxin, or ACE inhibitor. Which drug decrease the load, anxiety, and pain of heart? Thank you so much. Stay tuned.